us.
Dear Heavenly Father, thank you for this day, Lord. Thank you for bringing us together, Lord. Just be with us as we go through these proceedings, Lord. Help us to make good decisions. Lord, be with the sick and the shut-in today. And just be with us, Lord, as we continue throughout this day. Thank you. Amen.
Amen. Next on the agenda is roll call, please.
Bradley Cobb.
Need.
Janelle Fulbright. Here. Bill England.
Here.
Bill John Baker. Jack Baker.
Here.
Carly Buzzer.
Here.
Julia Coates. Here. Joe Crittenden.
Here.
Jody Fishinghawk.
Here.
Yeah.
Meredith Fraley. Here. Dawn Garvin. China Glory Jordan. Curtis Snell.
Here.
Chris Soap.
Present.
David Thornton.
Present.
Kara Cowan Watts.
Honey.
We have a quorum.
Next is approval of February 12th minutes. Have a motion for that.
So moved.
Second.
First and second, all those in favor?
Aye.
All opposed? Motion carries. Next we have reports from the Claremore Service Unit, Hastings, and Cherokee Nation Health. First up is Marty Smith from the Claremore Service Unit. Yes, Councilman Fishinghawk.
We just got these reports and we read them. Could you ask this group to start, not even 10 days since they're just reports, if they could get them to us maybe 5 days or 2 days in electronic form so we could at least make notes on it?
I have had, and this is a good point, I've had a request from actually several counselors, and I know Melissa's out sick today. When Dr. Grimm comes in, I'll say this again. I've had a request from several counselors if we could maybe get these 4 or 5 days ahead of time, because there are some people that want to look at some of the documentation. If that's at all possible, that would really help. So I'll mention that again when Dr. Grimm comes in the room. I think Marty Smith from Claremore Service Unit is up, and you have the floor.
Okay, thank you. Good morning, everyone.
Good morning.
I guess the first thing that I will go over is some of the what we're doing with our OB/GYN plan. We currently, last Friday, began installation of the floors into labor and delivery, recovery and postpartum rooms at the hospital. And I think I mentioned this before, but this is kind of, these rooms will be designed along the order to where the mother and the family and et cetera will be in the room right up until near the time of actual delivery. So it's more family-oriented, patient-centered care. Along with that, myself and the clinical director and our chief nurse executive went and looked at some rooms in Gallup, New Mexico, at how they had remodeled their rooms and provided the equipment for them, and just to look at their processes in general to see if we could learn from what they had done to improve the situation at Claremore. We also have had our nurses engaged in epidural training, to where we can provide an epidural service for the patients that would like that service. And so we're kind of at a point now with that program to where we're going to try to bring in an OB doc, maybe as, if not a chief of service, but possibly the chief of service, and a couple of nurse midwives, so that we can, as we move on through the process, we'll have some specialized input from the physician. As far as future plans and initiatives, we've spent some time analyzing what type of CT scan to replace our old one with. Our old one is what's called a single slice. It's real slow, overheats. It's only 5 years old, but it's amazing how much technology has changed in the last 5 years. We're leaning toward a 64 slice. It's more expensive than like there's a 16, a 32, and a 64. We're trying to hedge against the technology changes and get a 64 slice. We're thinking that we could minimize some of the costs that we're currently incurring by referring patients out to have heart caths. It also would be less invasive, more convenient. There's several things we're looking at as we're doing that, but we're working with Oklahoma City and getting their input also on what their perception of whether which technology to pursue. We're also in a situation where our storage space on our servers are getting low, and rather than replace the servers, our information technology chief has advised us to purchase 6 new drives. These are the computers that support RPMS and the electronic medical record, and so we plan to do that very soon, like as soon as we can, actually. Probably by the time those drives are out of space, the machines will be out of date, so we'll have to replace the machines at that point. I'm sad to say that one of our doctors that has been the chief of our emergency medicine department for several years passed away this last week, and he had been there for some time, and he was getting he had a minor illness, and actually it was Dr. Bobeck, Dr. Don Bobeck, actually had a unexpected death following, I think he fractured his ankle was the initial thing that happened. On the good news, we're getting Dr. Cheek, an internal medicine physician, is coming to Claremore from Hastings. She's scheduled to be there on March the 17th. This will help us out a lot because we have one internal medicine doctor that's out on an extended with an injury, and we have another one whose daughter is having heart surgery and is off for an unknown amount of time. And so it will help us on the internal medicine service to have Dr. Cheek there. We also have Travis Scott is at work now, working as our ambulatory care manager, and we're having him look at things like canceled appointments, missed appointments, provider productivity, that type of thing is what we're going to be asking Travis to analyze and try to help us improve some of those situations. And unfortunately, Dr. Cobb was correct at the last meeting when I was saying that our data was improved from the year before. As you look at the statistics for this month, it's actually probably the first month that we've noticed a decline in collections due to our physician shortage in several of the departments. We're still currently at about a 30% vacancy rate with the physicians. We do have a physician coming for a site visit, another ER physician. We could potentially have another surgeon. We're waiting to see on that. And we had a nurse practitioner that came for a site visit. So we're aggressively trying to get our staff level back up so that our patients will, it will help improve the backlog of appointments, and once again, the more when we have more providers, the visit count will come up. When the visit count come up, the revenue should also come up. Once again, some good news is our PCC data entry people are doing a good job. They're backlogged 4 days. There are places that have a lot more significant backlogs than that. So, in other words, the faster the visit is processed, the faster it goes over to the billing software, and the faster that the revenue comes into the hospital. And once again, our billing people are doing a pretty good job with the accounts receivable. The percentage of accounts receivables that are 120 plus days is 4%. I think the national goal is to try to have it under 10%. And so they're doing, is it 10 or 20? It's 20% to put you in perspective. So they're doing a pretty good job with that. And of course the collections figures I listed for you there, but in short, that's pretty much a summary of how February went.
Any questions? I have one. What is, in your opinion, what's the biggest reason for the physician shortage at Claremont?
You know, I should have brought an article from USA Today. I think I mentioned last time there's a lot of contributing factors, but just in general, there's a nationwide shortage. And this article from USA Today, I can scan it and forward it if you would like. It's pretty interesting. It highlighted surgeons, but when you really looked at it, it looked like that the general practice doctors were the ones that were the least of them available. And then it talked about the decreased admissions during the 80s in medical schools. And so there's a variety of things, but relative to us, specifically as an agency, we're competing, I think, a lot with the VA. And I was telling Dr. Grimm earlier that if you do a Google search for a federal physician vacancy, it'll probably take you to usajobs.gov. And if you look, it's just saturated with VA vacancies. And the way our vacancies are not really getting posted like they should. I pointed that out to Frank Williams, the Director of Field Operations. And then another intrinsic problem is, with the IHS website, most doctors, if they're looking for a vacancy, I would suspect if a doctor was looking for a vacancy, they would search for physician or doctor if they were sorting. But ours are posted out there in various ways, like medical officer dash internal medicine, medical officer dash family practice. And so unless you know how to look for the jobs, you can't find them very easily. So having said that, we have our own problems too. The shorter the staff shortage gets, the worse, the harder it is to recruit physicians, because they walk in and see how, what the volume of patients is, and they don't want to go into that situation. So that's a big part of the problem too.
Councilman Cowan-Roth?
In long term, we're going to have issues because I believe the IHS funding for scholarships and payback programs has been slashed in the last couple of years, and nobody's putting that as a focus. Like, we as a health committee could write a letter to IHS about how appalling this is, because it's going to just compound and make it all worse.
Second that.
Okay.
We have
For you to do.
Dr. Grimm, do you have a comment?
I was just going to say the other thing is, if you look at statistically nationally, Oklahoma rates last in the ratio of physician to patient. So we have the highest number, like one physician to X number of patients, and we have the highest number. So we have the least amount of physicians per patient population.
We have a motion on the table. Could you restate that, please, Council?
A letter from the Tribal Council of the Cherokee Nation to Indian Health Service, as well as our Oklahoma representatives, stating that the critical need for the IHS scholarship money and payback money. The payback money could apply to non-intensive ones to serve our population as well, but it's all been cut from what I understand.
So we have a motion on the table for a letter from the council, and we have a second. All those in favor?
Aye.
Any opposed? Motion carries. Any more questions? Marty, appreciate it. Thank you very much. Next on the agenda is Ed McLemore from Hastings.
Good morning, Mr. Chairman, members of the committee.
Morning.
Ja, diese dagen, nej. Ja, det jag hittills alla. Det var det skadade, kan det stå. Då det den på vägen gasten idag hur var det gast det disken gässa. So I'm glad to be back, give a report. To give a report, you know, it's turning springtime outside. We've got a lot of activity going on. Hastings, it seems like it's always springtime for us. I mean, we have a bright outlook at Hastings. We've been working closely with the Cherokee Nation teams, looking at different functions at Hastings. We hope that there's a favorable decision reached on some of the activities that are going on. I think we have a lot to offer each other in partnership as we move forward in this decision-making process on the project that we're considering. We've given you a snapshot of Hastings. I think this is the same information we gave you in our last report, but it gives you an idea of what we're looking at when we deal with the patient workload, the number of visits, almost 250,000 visits at Hastings each year. We've grown, we grow by about 350 to 400 new charts per month. People continue to come to see us for services. Talk about physician shortages. Claremore has done all they can do to help us experience some shortages also with physicians. They've been very successful at recruiting. Captain Smith mentioned Dr. Cheek. Their gain is, of course, our loss, and also the Chief of Dietary Services at Hastings. Their gain is also our loss, and we seem like we're a training camp for Claremore, but that's all well and fine because it helps Indian people within the Indian Health Service system, and we're happy to do that. And we'll return the favor one day. And, I know Council Member Fishing Hawk mentioned the lateness of our report. I apologize for that. We'll make sure that doesn't happen again, so that you'll have an opportunity to look over the information before we actually stand before you to answer questions. But I would entertain any questions you might have. All of these items are, to us, highlights, but we'd be happy to respond to any questions or issues you might raise.
Are there any questions from Mr. McElmore, Councilor Fishing Hawk?
Yeah, how's it going on the mail pharmacy, the
Mail order?
pharmacy orders, yeah?
Well, we've run into a little bit of difficulty. We actually have Pitney Bowes scheduled to be on site tomorrow to install the equipment, and we have had some problems because the post office was unable, our local post office was unable to accept EFT transfers, and we've worked out those difficulties, and now the only question is testing the labels and sizes of the packages and that sort of thing, and we expect that to be done in about 2 to 4 weeks, hopefully 2 weeks after installation of the equipment tomorrow. So hopefully, if everything works out fine, we'll be able to get that system up and running by the end of this month. I know we've said that before, but you know how it goes with red tape.
Thank you.
Councilman Baker?
Yeah, I would, before the meeting, I mentioned to Ed that business must be bad at Hastings and it must not be doing very well. Their report is not near as fancy as it's been in the past. But he said that they lost their graphics person, so.
Well, as a matter of fact, Councilmember Baker did raise that question, and I would point out the last page, the information on the last page. As of the end of February, our third-party collections are ahead of last year by about $500,000, and that was even without Medicare Part A being fully paid. We had experienced some problems with Medicare Part A because of our national provider identifier data information mismatching with what was on file at CMS. And once we worked out those mismatches, then the pipeline opened up again, and as of yesterday, we had received about $1.1 million in Medicare. So the pipeline is now back open, and we should see even more of an increase. I think we're on pace now for about $3 million over the $33.1 million we received last year in alternate resources. So we could be looking at possibly, if everything were to work out fine for the rest of the year, about $36 million in alternate resource collections.
And then you started off with what all the tribe has to offer Hastings and Hastings has to offer the tribe.
Yes.
And so I assume that there are talks going on, whatever, to about something that was mentioned briefly that the tribe was considering taking over the hospital, but this body really hasn't heard anything unless folks are hearing stuff that I'm not. I was wondering when we might start discussing, you know, the pros and cons and whether that's something that the tribe really ought to do or not.
My understanding, and I have not heard anything, my understanding is that we have a feasibility study, and when that's completed, they're going to bring it back to the council, and then that will be the time for discussion. That's my understanding.
Well, that's also my understanding. And right now we have teams, joint teams that have been organized with Cherokee Nation participation along with Hastings, looking at all facets of Hastings operations. And that's to gauge the status, the baseline status of Hastings before the Cherokee Nation can even determine whether or not they would want to present something. That's my understanding. I'm not.
That's correct.
And we would not be in on that decision making. We're simply providing information and providing a look at what Hastings operations consist of, so that the Cherokee Nation would be well advised about what they would be undertaking with that sort of proposal.
You know better than anybody that at best it's extremely complicated.
Very much so.
And I just think that maybe some dialogue with this body as they're going along might not be a bad idea, rather than drop it on us in June and expect us to take over in July. And I think this might be the most important decision made in the last century for the tribe, and it does not need to be made lightly.
Councilor Buzzard.
Yes, Ed, is it I'd like to request that you'd also include on your reports the backlog of the PCC operations at Hastings.
Okay?
And I want to ask that, I'll ask that with the Cherokee Nation clinics in a little bit. But on the other hand, I see that but John Doherty's retiring from the Indian Health Service.
Yes.
Is there any rumors in the mail who's going to be moving up to the director's position?
Well, that's a lengthy process. For example, the Tucson area director retired, I think, in January of last year, and they're just now getting around to filling that. The area director in Aberdeen retired, I think it was in March or so of last year. They're just now announced the person, Charlene. So it takes a while. That's a senior executive service position. And it requires clearance by OPM and the department, and then the selection process within the Indian Health Service. It's a fairly lengthy. So we have not gotten any indication about who might be Mr. Doherty's replacement on a permanent basis. Now, there have been some discussions about an interim person coming in. But a number of names have been tossed around. What they want to do is bring someone in from another area to take over on an interim basis. At least that's what the discussion has been.
Okay. All right. Thank you.
Are there any more questions? Thank you, Mr. McElmore.
All right. I would comment before I sit down on your question about PCC backlogs.
Yes.
With the electronic health record, we really don't see much of that. I mean, we do have some of that in I beg your pardon, the ER and in the ambulatory surgery center and that sort of thing. But for the most part, the data entry occurs at the point of service. And so we can provide that, but it will be very limited because we've almost gotten to the point of 100% EHR in both outpatient and inpatient. We've started that process.
That's good. Thank you.
Apologize for the add-on, Mr. Chairman, but that concludes my report.
Thank you. I believe Melissa Gower is under the weather, so for Cherokee Nation Health Services, we have Dr. Graham.
Thank you. A couple of things while they're still on my mind. Our PCC data entry stays very up to date. We have a 24-hour turnaround time that is in our standards to meet, and we are very good at meeting that, so we haven't had an issue with that. Second thing is, do you want me to go ahead and have JT draft a letter for the council to send to IHS? And
I think that would be a good idea.
okay. I'll have him draft something and then send it over here. As far as this past month, some of the big things that have occurred, and I'm not going to read this. I know that you all have had the opportunity to read it. We had the super colon and here in Tahlequah, which was kind of a fun little event just for colorectal cancer awareness. The other thing we did around cancer awareness this month was we had our second annual Cherokee Nation Cancer Summit in Tulsa in conjunction with the University of Oklahoma. Kara came and found it beneficial. We got very good comments. It was very largely attended. We had about 250 participants nationwide.
Ed and I were the only ones that didn't cry during that one presentation.
Oh, I know. Yes, everybody cried, so we had a survivors luncheon, but I didn't cry.
Okay, there's three of us. Everybody else at the table was just bawling and get clean.
Yeah. Everybody at my table was too. I felt bad when I wasn't crying.
How does that work?
But that went extremely well. The Muskogee Three Rivers Clinic is up, going. Every day it's getting better. We're starting to see more patients every day. They're working out all the little bugs that need to be worked out. They're going to come in and do their final checklist and get all the final little repairs done. But I've heard good things, and I hope you have too. So I think it's definitely picking up. Will Rogers Health Center, we do have our radiology services going there, have our new HPDP educator going there, and it's open, it's running smoothly. Still a few things that we're waiting on as far as equipment for both places, but the transitions have been as smooth as you would expect in big moves like that. The other big thing, and I know some of you have seen on your email, is the Cherokee Nation Community Anti-Drug Network Project. We've been having meetings with communities and had lots of participation, lots of interest from the communities, and they're all very active. So I think that program is going to be very successful. The only other, big issue, which has been consuming a lot of time, is the Hastings analysis. We have, as Ed said, broken into about 15, 16 small groups that are looking at various parts of Hastings, varying from facilities to medical services, lab, nursing, dietary, all different aspects of Hastings. And right now, all it is an analysis phase, and it's a very thorough analysis phase. The teams are required every week. They have a project list, and every week there's some deliverables that they have to submit, that this is what they looked at, this is what they talked about. The team consists of people from Cherokee Nation and Hastings. Also, we have area office providing a fair amount of input regarding employment issues and federal employment versus commissioned officers. So they'll be providing information. We are and have done some employee meetings there at Hastings just to make sure that they're aware, to try to keep the rumors down, that they're aware that we are going through this evaluation process, and that's what it is until a decision's made. And we want them to make sure that they know that this is occurring and try to stop any rumors to keep people from feeling insecure in their job. The plan will be, once we get this report compiled, to bring it to this committee and discuss the findings with you all.
I have a couple things myself. Was that your?
Yeah, go ahead.
Can you briefly, and this may be bringing back some stuff for another time, could you kind of briefly, do you turnover rates within our clinics and facilities?
Or
how basically, what is our turnover rate for physicians,
just for
PAs?
For physicians and PAs, our turnover rate's been extremely low. If you look at our existing medical staff, most of them have been with us for a very, very long time. We've had, at Salina, all the people there have been there for a very long time, except we've hired some more as we've added staff. At Nowata, they've been there for a long time. We lost Dr. Foreman, who had been here with us 10 years, but the other people have all been there. Benita and Bartlesville, they were both there when those two clinics started, and then the other two have been with us for a long time. They're in Nowata. In J, we have had Dr. Underwood's been here about 9 years. We have a new physician there. And nurse practitioners have been there for 4 years now. Stillwell, Dr. Reptoy was relatively new. We've had a pediatrician that's been with us for 12 or 13 years. And at Salisaw, we had a little bit of turnover there. We lost a couple of people. One person was killed in a car wreck. Then we lost Dr. Troe.
Are those numbers available?
We have them, and it depends on how you want to, we can give you like an average length of stay.
Do you have it per facility? Maybe over the last, 2 years, I don't know if 2 years is quite enough time actually, maybe a 3 to 5 year kind of what you're looking at per facility, what a turnover rate is for, I'll cut you down here in a second, for the various facilities. And I've got a couple more things, but I've got some counselors that had some questions, and but if you don't mind, I'd like to see those, just kind of see the turnover rate. Councilor Garvin had a question.
Thank you, Mr. Chairman. I've had a bunch of good comments on the Three Rivers Health Clinic, but I'm getting a little flack from non-Indian friends. They're quite jealous, and they want me to get them a card so they can use it.
I bet.
So I guess I've lost a few friends, non-Indians, but that being said, you and Dr. Cobb and I had a meeting with the new Muskogee Hospital. I don't know the name of it. Could you tell us a little bit how that's progressing, or did we make any progress?
We have, and Mr. Roberts has called me back, and we're going to schedule some time to follow up with him. And then as far as the ophthalmology goes, I've talked with Dr. Welch and with Dr. Foster, and we are pursuing getting a retinal specialist in with the creeks and the chicks and the chalks, maybe just whoever would be good to help look at that as a...
So it's going to take a long time to get it worked out.
Well, I think the ophthalmology piece, we can probably work out if we can find somebody. With the new Muskogee Hospital, until they really get up and running, I mean, we're just kind of planning along with them to see.
I don't think it's going to open until about a year from now.
It'll be another year. So.
One other follow-up. What kind of security do we have on the new?
We have security guards, but they don't carry lethal weapons.
I was out there last night, and I was driving around, and it's kind of a little bit isolated, you know.
It is.
But we do have someone.
We do have security guards, and we have a really good security system in place that we've tested multiple times for response, to see how quickly we get response, and risk management says it's working extremely well.
Okay. Thank you, Mr. Chairman.
Councilor Fishing Hawk.
Yes, when you do the turnover rate, I would like it to go back 10 years
Okay.
because of your IHS scholarships and how the repayment is. And I like it broke down by facility and by provider, like doctors, PAs, RNs, pediatrician,
Yeah, that's a good point, because with our dentists, after 4 years after their payback, they're gone.
That's what and then another question. I'm going to be sending you 2 or 3 questions, but this one I'm very much interested in. I want to see some quality care benchmarks. I'd like to see our clinics compared to other profit places. I wrote 2 or 3 things down, like our blood pressure. If the blood pressure is under control, your diabetes with your A1C under 7. I know we do tobacco and alcohol screening. And the screening rates for your breast cancer, colorectal. I want them broken down, and I want to see benchmarks. And I want to know how we can compare on our preventative type stuff that's going to matter 10 or 20 years down the road to other for-profit places.
You asked for perfect timing. We do GIPR, which is the Government Performance Government Performance and Results Act. Thank you. And we do that. We do it monthly, but we just did our mid-year report, and it does all of those things. It measures everything you just talked about: A1C, blood pressure control. It does mammography screenings, colorectal screenings, pap smears, and we have all of those statistics, and then we have the benchmarks, and we'll bring those. We just got the report done. We're actually doing very, very well on our benchmarks. If you compare us to IHS, and we are above what they have set as their benchmarks, and where they are at and their goals, we are consistently above that. And for a lot of things like A1C, blood pressure, we're extremely above. The things we fall a little bit below in nationally, we fall a little bit below in mammography screening. And that's something that we hope to be able to resolve. We're going to get a couple of new mammography units. I think there's a real need for one in Tahlequah. I think that's been one of our biggest areas. So that's been a little bit below. Colorectal cancer screening, we're very much above average on that, so we're doing really good on that. But we'll bring you the whole report.
Okay, we'll have comparatives to other places to show how we stand.
Yeah, and I don't know if that's something that at some point, because that's something we're doing really well, if that's something, Brad, you all would ever want as a presentation, we could, just let us know and we could present it to the whole council. I mean, we just did it, so.
When you, it sounds like you have the data available.
We have it readily available.
Why don't you get this get together after
Okay.
that, and I will get that on the
Okay,
agenda.
that would be good.
That's all, thank you.
We can give it to you ahead of time too, because
Oh, good.
you sound like me because you want to.
I want to read it. I figure they're going to be pretty high. I want to compare them to
Yeah.
show how well we are doing.
Okay.
Okay, thank you.
Councilor Buzzard.
Yes, I have 2 or 3 items here that I want to bring forward, but the other thing is on the vacancies. And you may have addressed it, Dr. Cobb and Joey, but I'd like to see the vacancies for each facility that we do operate. The other thing is on security that Councilman Garvin mentioned. I had mentioned this too in a letter about some cameras installed at clinics. I really believe that we need cameras in these clinics. Security's fine, but I also think you need to have some cameras in there. I'd make that suggestion to go forward if we could get those done. The other thing is the providers. I think at the J clinic there, I think we are short providers, and I think I'd like to see the vacancy list. The other thing is the PCCs. You mentioned a while ago that you were pretty much up on the date of the PCCs, but I've had some people talk to me, and I've also experienced this, that I will go to a specialist outside and my deductible is not met. Does that go back so when you put the PCs into the systems to meet the person's deductible, to go out to a specialist?
No. That goes back to our health insurance that we have as employees. And with our plan, our health insurance plan, our plan document says, and Jenna, correct me if I'm wrong, but I believe our plan document says because Cherokee Nation clinics don't charge for the copay, that whenever you come to Cherokee Nation, that it does not count towards your deductible.
Now say that again. When you,
like if you come to Cherokee Nation,
yes.
and we bill for the services, but it was a special arrangement that we had made with the insurance carrier, and because we don't collect a copay because it's a tribal facility, they don't count that visit towards your deductible.
That's news to me.
You're not giving the option.
And I think that has.
It's confused a lot of people.
And I think that has remained the same for a while. And you might ask HR, ask benefits, but I'm almost positive that that's the case. It used to be the case.
Okay.
Is it still the case?
So it is still the case?
Butler thinks and said, and I'm almost, I'm at least 90% sure, because I don't think that changed in our last insurance when we put it out.
So the PCCs really in our Cherokee Nation clinics is not having the effects that Mr. McLemore does at Hastings Hospital. And you say we're pretty much up to date at our clinics, though.
Yeah, I mean the way we do, we do our data entry from our PCCs, and then we do billing centrally, and so, and it's a little bit different for Ed than it is for us because we can bill Cherokee Nation health insurance. IHS facilities cannot bill Cherokee Nation health insurance.
So if we're up to date on our PCCs as far as billing the Cherokee Nation health insurance, so we're collecting all the
We're collecting
insurance.
the money.
Okay, thanks. That answers the question. I do have some concerns about the deductibles on the insurance.
And that may be something to talk to Michael Botello about,
Okay.
and the insurance committee can, it'll be up for rebid again, and that might be something they want to alter on the plan document.
Okay, because I really think that a lot of employees probably use these facilities thinking that's what's happening, and I'm surprised to hear that. Okay, thank you. Thanks, Dr. Cox.
Any more councilors? Councilor Fulbright?
This is just Cherokee Nation employee insurance because my husband has a different insurance and it counts on his deductible, and it doesn't really seem fair. I mean, I don't know why there would be an exception.
It was something that was put in the plan document, and I don't know,
Was it to discourage it? people from
No,
using?
it wasn't. It was to save the insurance company money. And I mean, that's why the insurance company wants it done, obviously, is it saves them money. And I'm not for sure, Ginger, about why we agreed to. Yeah, I just don't.
Well, it was just news
Let
to
me-
me because I was just used to my husband's insurance.
Yeah,
and
and
it always counts.
it does. It counts
Let
towards
me
the
interject, because one of my questions is along these lines. Are we talking about the Blue Cross Blue Shield?
Yeah.
Okay.
Yep.
So IHS does not file that. I mean, I'm talking about Claremore. Indian Health Service does not.
IHS can't bill for any self-funded tribal insurance program. It's against the law.
Okay, that's, okay.
And since we're self-funded, they can't bill.
But if and I'm sorry, Councilor Fulbright, I'm stepping on your question, were you?
I'm through.
If a citizen went to the Claremore Service Unit area and was not an employee of the Cherokee Nation but had Blue Cross Blue Shield, that they pay, could they file it?
Well, they could, but, and I can talk about this more because it hasn't impacted us the way it has IHS, but they've had some issues with Blue Cross Blue Shield paying, and I don't know if that ever got resolved.
Well, actually, the problem was related to whether or not Hastings could be considered part of the provider network for that payer. And they had three objections. One was that all of our physicians are not necessarily licensed by the state of Oklahoma. Some of them are licensed in other states. They're federal employees on a federal facility or at a federal facility. The second was that we were discriminating against non-eligibles. I mean, we have a limited eligibility base. A person of Indian descent, for example. And the third objection was that we did not have professional liability insurance for our providers, that we were in fact covered by the Federal Tort Claims Act. And so because of those three objections, we were excluded from participation as a provider within the network of Blue Cross Blue Shield of Oklahoma. We still send in claims, and we still on occasion get paid, and we get paid on the federal side for our own employees, but it's been a very difficult process in trying to even negotiate with Blue Cross.
I find that fascinating, bringing that many people to the table covered under health insurance. Do you find that a normal occurrence with other carriers, or just Blue Cross Blue Shield?
It's only been with Blue Cross and Blue Shield of Oklahoma, and it is fairly apparent to us that it is a designed exclusion to save money for Blue Cross and Blue Shield. They collect the premiums, but they don't pay out any payments for services. So, I mean, that's what it appears to us to be, a money-saving device.
Business policy.
Councilor Fishing Hawk has a
Well,
question.
Margaret, could you have somebody come in here and report on that, especially if bids are coming up, or we're going to re-let that out? Because I almost feel discriminated against. I'm rolling that around in my mind right now.
Who would you suggest come in and give us a discussion on that topic about some of the inconsistencies with insurance filing if you're an employee of the nation? Who would you suggest come in and maybe?
Well, I think Michael and Amy need to come in and address the employee insurance issues specifically. If we want to broaden the topic ever to discuss some of the issues that IHS in Oklahoma is facing, then we'll need to kind of strategize, because I mean that's going to get into some.
Let's we've got two things. We've got another, you actually three things. You have a letter drafted, we're getting back on having a special, this will be the third thing. We need to get together, and this may end up being some kind of a special, let's just see what we can do without jamming everything into one health committee here.
Okay.
Yeah, because I'd like to figure out why Blue Cross and Blue Shield, if the other ones would do it, if there's other healthcare providers out there, as many people as we bring to the table.
Okay.
And that is, and the issue Ed's talking about, we have not faced at the tribe. We, Blue Cross Blue Shield has paid us very willingly, and I don't know, one, I mean, it's in their best interest because we turn around and contract with them for our employee insurance. And two, we've avoided some of the things that Ed's talking about in the sense that we've made all of our physicians and anybody licensed, dentists, mid-levels, whomever, dietitians get Oklahoma license. So that takes care of some of those billing issues that he's talking about. But
Well, I'm just a little concerned that someone that is a tribal citizen, irregardless of tribe, can go to an IHS facility, and if they pay private, they have insurance that they privately pay for that it's accepted. And I don't mean by IHS, I just meant by, but yet if it's funded by a tribe, it's not. I find that a little disconcerting, to be bluntly honest with you. So, Councilor Buzzard.
And that's, I feel the same way, Dr. Collins, because I believe that the Cherokee Nation Enterprises is also covered by Blue Cross Blue Shield.
they are.
There's some discrepancies between the actual prescription, because we just experienced this just recently. So yeah, that's something I think needs to be looked into, because if we as Cherokee Nation and Cherokee Nation Enterprises are paying this company huge sums of money, then I think we need to see what's happening. Thank you. Thank you.
I have a few things real quick. I know this email's gone out. I apologize. You got a bunch of homework here today. I've had actually several counselors ask me, and I think some of this is in reaction to the feasibility study. Some of it's in reaction to some other things, but there has been several questions. Some of the counselors want to know where we stand on pay scale versus other tribes and versus the VA system throughout our health system. And I know that's kind of a bigger project, but I'd really like to.
And it's a bigger project that's actually being done right now. The HR group with Michael Botello and Alana Castile have hired a outside firm to go and look at all jobs within Cherokee Nation, not just health jobs, and all jobs at Hastings, and look at how we compare as far as fair market pay to other entities in the area. And so they are actively doing that. They're supposed to have that done by April 15th, and it's for everything.
Okay. When that's, somebody will let us know when that's available.
Yeah, and we'll send some of this along to Michael so he'll be aware of what's going on.
A couple other things real quick. Why not, I don't know if lethal weapons is the word I want to use, but why not lethal weapons at Three Rivers?
That's the first time that we've ever probably faced the issue where we've had a large enough facility that we need that. And it's just something that we've never chosen to do, and it may be something that we have to revisit at some point. We've just never had anybody that carries a gun as a security guard, which in and of itself creates, some issues. And security is not my expertise by any stretch of the imagination, but I think that there are some other alternatives that we could probably use that we don't, which are tasers and those kinds of things.
And that's where I'm going
which
with this.
are non-lethal, but
That's
still
a
very.
big parking lot, and if it was dark and I was, was there for quite a while and had parked way out, and then, that's all I'm asking. It's not necessarily lethal weapons, but as long as somebody's looking into it.
So yes, that needs to be revisited, and I think that tasers may be
Can you tell me real quick, and I still have two counselors, but can you tell me real quick about when somebody applies for a job, my first question is, especially with the way gas prices are now, is it looked at is it factored into the equation how far they're driving, time of driving, and B, can you tell me a little bit about once you're hired on, and I don't know if this is within the entire nation, but it seems to be in the health service, that there's a 6-month period there before you can transfer to another facility. Can you touch on those two things real quick?
When somebody applies for a job, they usually apply for a job at a specific location. And if we have multiple jobs open, they may apply for the one closest to their home. We don't necessarily always look at that. The times we have, for example, we're getting some housing authority, the staff that, I can't remember the exact wording, but didn't have non-competitive or competitive jobs to move directly over. And so, we're interviewing some of those people right now. And we are looking at those employees who are interviewing with us and trying to place them at the site closest to their home. We had a young lady that interviewed who was very good here at Tahlequah, but she lives in Vian, and she also interviewed at Sallisaw. And so, of course, we went ahead and selected her for the Sallisaw job then because, it was much, much closer to her home. But on a routine basis, we don't. With gas prices now, we've had a few people who will now come and say to us, if something opens up, I want to move to X place because it's closer. And so we're trying to pay a little bit more attention. Last summer, there was an effort made, and I don't think it got off the ground too much, to try to do some carpooling and some Cherokee Nation sponsored, trying to do a little bit more of a group travel to get people to and from work, but I don't think that
there was an instance.
Made off the ground.
There was an instance, and you have to realize as counselors, we're the ones that come here from the constituents. There was an instance recently that there was a new hire at one of the clinics, and the individual had wanted to work at a facility that was very, very much closer to where this person lived. And actually, that wasn't given to them. They were hired at another one, and within 3 weeks, someone was hired that was actually further away from the facility that this person originally wanted to work for, and it would have been
easier to swap them.
Yeah, it would have been easier to swap them, but both of them were hired, and they were in the 6-month window where they couldn't.
And we've swapped people before.
But they were told that they were in a 6-month. That first 6 months you can't transfer. So that was basically the response that I got: is they're already hired, they're within 6 months, and we can't do anything for 6 months.
And
I just didn't know if there were any exceptions to that.
Yeah, there's an exception to every rule. So.
Okay, well that's fine. That was
because you got to look at the best interest of the clinic and the employees. And, if gas is going to get $4 or $5 a gallon, people are going to have to.
And I got one more, and I got 3 more counselors. I got you, just without going into too much detail, regarding Councilor Garvin's question about our meeting over Three Rivers, the individual we're talking about is obviously a business-minded individual and kept coming to me with certain things, and I felt like we were kind of crossing the line on. And some of those I referred to some of the C&B people.
Yeah.
So you may want to maybe get with me after, and I'll kind of tell you how that.
Okay.
I thought that C&B some of those were business ventures, and I thought much better handled by C&B than me. Councilor Soap.
You mentioned that there's an outside firm studying all the jobs available at the nation and so forth, and then you mentioned earlier that Oklahoma is apparently last in the ability to recruit and the doctor to potential patient loads. So is this something that we can check to make sure that we're not just comparing the area as Oklahoma
Since we're not recruiting anything?
last place, and see maybe to go make sure that, or at least try to get a regional outlook or something like that.
Yeah, we can do that.
Councilor Fraley, excuse me, Madam Speaker Fraley.
I was reading in the dental program report here, there's nothing about the Salina Dental Clinic.
I just thought I'd ask you again, what is the status?
We are still, there are two things that are right on our top of our list, and that's one of them. And then we're looking at the Jack Brown Center, so that's.
Which one's number one?
Say dental.
Pressure, I'm going to go ahead and say Salina Dental Clinic, but Melissa has the right to override that when she comes back, so she can override that Salina Dental Clinic. But I'm going to say that today.
Okay.
But I mean, they're both actually supposed to start simultaneously, so, and I think they will.
Do you have an
I mean-
estimated date?
Hopefully,
Year, month?
before we start construction.
Yeah.
We've got to pull out the old A&E on it, and I mean, I think that they're actually hoping this summer to get some of that up and going.
Okay.
So,
That'd be
and one of the big things we're waiting on was our staffing dollars, which we've now got, or in the process of getting from Discovery, and that's how we're going to staff it. So it's just a matter of, funding that expansion, and we're looking at doing another bond to finance it, and we're going to put all of that into one bond. So really, they are pretty much simultaneous. We're going to put the Jack Brown Center and the Salina Dental into another big bond proposal.
soon.
Soon.
Thank you.
They've actually met with the bonding person this week, I believe. So.
Councilor Fulbright.
My question is, when you're trying to recruit a new doctor, do you have a set guideline that has got the maximum that they can be paid, or do you have any room for negotiation with that person?
We have tried to have a pretty standard pay scale, and the pay scale, takes into account experience, specialties, any additional educational certifications the person may have, and we have found that has worked a lot better for us in the sense before people were making all kinds of different salaries for doing the same job, and it was more, no offense to anybody in the room, it was more of at that point, more of a good old boy who you kind of, when I started 12 years ago, than a real planned structure of pay, so that was fair and equitable. No offense to anybody in the room. Good old boys. I like them, so no offense.
Are there any more questions? I appreciate everyone's patience. As you can see, there's some interest in health, so
That's good.
appreciate your
I'm glad. Thank you.
Thank you very much. Next is old business. There appears to be none. New business. There appears to be none. And, wait. Somebody's pointing at
We do have Michael Botello from HR here if you have any questions.
Are there any questions for Mr. Botello? I know Dr. Grimm mentioned there was a...
Mr. Chairman, I make a motion to adjourn.
Second.
Oh, well.
Well, I guess we won't hear from Mr. Patelli then. I'm certainly interested in the insurance issue. If we can bring him back next month, it's fine with me.
Yes.
And it's not.
There's a motion on the table to adjourn, and it has been seconded, but we had a request that Mr. Botello come back next month.
We can do it right now if you want to. I'll withdraw my motion, we can do it now.
And,
Everything's been withdrawn.
everything's been withdrawn. So Councilor Buzzard, you're on the floor.
Yes, we'd like to have Mr. McCullough up front if we could.
It's like it's not me this time.
Good morning. My name is Michael Botello. I'm the group leader of Human Resources, and if you had questions for me about the health plan or anything else, I'd be happy to try to answer those for you.
Councilor
Well,
Buzzard.
my question is, Mr. Patello, is we have insurance through the Cherokee Nation as an employee or a council member. And we go to our health clinics, and what I just heard and understand that the deductible is not deducted at our Cherokee Nation health facilities. Now, I was under the impression that was happening in the years past, but I'm just told a little bit ago that it's not. Do you know why it's not?
First of all, the deductible generally only applies to certain types of services. And if those services are being offered at clinics, then my understanding would be that those would be applied to the deductible. But, deductibles are generally applied to inpatient services, which, we really don't offer at clinics, inpatient services. So deductibles apply only to certain types of services. Other types of services like office visits, things like co-pays would apply to those kind of services.
The other question is, I know Cherokee Nation Enterprises has Blue Cross and Blue Shield also, but I do know there's been some difference in charges as far as the pharmacy business goes for prescription drugs. And, if we're the Cherokee Nation and Blue Cross and Blue Shield is serving us, I don't see why we can't all be treated on an equal basis. Is there some reason that you know of that's different?
Yes. The last time that we renewed our relationship with a TPA, a third-party administrator, we partnered together with CNI and CNE to, as one block of business, to get the best kind of services and rates that we could. And so we all together chose Blue Cross Blue Shield to be our third-party administrator, but each of us have our own separate health plans. And with each of those health plans, there is a separate plan design, which means the services that are covered and the way they're covered are just a little bit different. And that includes the pharmacy that you mentioned. The co-pays are probably a little bit different with each plan.
Okay, well, that kind of answers my question, but I guess I would like a list of the things that are deductible at our Cherokee Nation Health Clinics. Can you get that for us?
The things to which the deductible applies, I'd be happy to get that for you.
Thank you. That answers my question.
Councilor Fishing Hawk?
I'd like to see a list of the differences in the different health plans.
Okay. Back when we started partnering together with the other entities, we did a spreadsheet that compares those, and I can provide that to you.
Thank you very much.
Councilor Fulbright?
I was wondering, maybe it's in the fine print and I haven't read it, what is the copay will the Blue Cross Blue Shield plan pay anything to our Cherokee Nation pharmacies at our clinics?
The pharmacies at the clinics. I assume they'd be covered in the same way that any other pharmacy would be covered.
Well, the reason I ask that, I'm used to my husband's insurance, which is the world's worst. It is Oklahoma education employees and state employees, and they will not pay anything to the Redbird Smith Clinic if I go up there and get a prescription. They won't pay the clinic anything. Yeah. But I know other plans will.
Yeah, I think our plan would pay in the same way it would pay a
Like
retail
if it were
pharmacy.
downtown one. That's what I wanted to know. Because I'm always telling him this insurance is better than the one he has. But that's the question. It's for to know.
Any more questions?
Move to adjourn.
Second. I don't think I've gotten to announcements yet.
I've got one more question. Yeah.
Councilor Fulbright, I don't have a second, I don't believe.
Are you the person that is in charge of doing the guidelines on the doctors and providers' salaries, or was it someone else?
Yeah, I was talking to him about the study we're doing for all of the employee salaries.
Well, a lot of people have told me one of the reasons it's so hard to recruit is because of the pay, and that the incentive to come to work for us was the no weekends, no nights, and all that. But now the hospitals that I'm close to in Fort Smith, they have all hired hospitalists to make their rounds. You know what I'm talking about? And then their regular doctors, they don't make rounds on weekends, nights, or they're not called out. So us not having that's not an incentive anymore. So we got to have something else as an incentive, which I think it needs to be higher pay.
Well, she may have mentioned that we have engaged a consultant to do a comprehensive review of our compensation structures and salaries, and the market, and we expect to have that completed by May 1st in time for budgeting for this next fiscal year.
Well, the reason I was particularly interested, it seems like I'm from down in Sequoia County. We have an awful lot of doctors there that are local, and they're all working over in Fort Smith, and we want to recruit them back home. We've got specialists of all kinds and everything. It's always like the pay cut is too big.
Well, we hope to address that by comparing where we're at today with the market. So we certainly do hope to address some of those problems.
Well, this study, will it compare us to, say, for instance, the Choctaws? Because I keep hearing like they pay so much better than we do.
It's probably more geographically based. If they have providers that are in our area, then yes. But generally you want to compare favorably with those that are in your job market, which is a geographic comparison.
Thank you. I think we could probably look forward to having some kind of special presentation. We'll figure that out in the next few minutes. Thank you very much.
You happy to? Thank you.
I don't think there's any announcements unless somebody has any. We'll entertain a motion to adjourn.
So moved.
And a second. We have a motion and a second. All those in favor? Aye. Anybody opposed? Thank you. Motion passes.